So it's a 6-year-old boy is scheduled for an elective tonsillectomy.
Okay.
The indication for this includes frequency and snoring at night and daytime somnolence. He's asthmatic, on regular diclomethasone, and he's had a recent cold. His parents says he's better now. Did you get that?
Yeah, got it, just about.
Okay. So what would be your concerns, please?
Okay, so my concerns are, in this case, mainly based around the fact that I'm dealing with a child. So this is a pediatric case, which takes specific attention needs to be paid. And the recent cold this child had needs to be investigated, and I need to find out a lot more about that to see whether that will determine whether the case will go ahead or not, considering it's elective. And lastly, my third main concern is the past medical history of this child, which includes asthma, which is a risk factor for making any anesthetic more risky, really.
Right. So what would be your approach to anesthetizing this patient?
So I would first start by taking a full and detailed anesthetic and general medical history from the patient. And I would examine the patient, of course, in this case with the parents present. I would make sure that I pay specific attention to the history of this child's asthma, whether they'd ever been in hospital with it, intubated, ventilated on ITU. And of course, in this case, I'd also be interested in the pre and postnatal history, and whether there was any complications in the neonatal period or recent childhood, whether the child has any other medical conditions. I'd also make sure that on examination of the child, I elicit whether there are any signs of current respiratory compromise, whether that is from the asthma or from the recent lower respiratory tract infection, which I should add, I also want to find out a lot more in the history about, so how long has it been going on for, when did it stop, and how severe was it really, how was it treated. I would make sure that I perform appropriate bedside and laboratory tests, such as a peak flow by the bedside. I'd need to make sure I can see a full blood count to check for inflammatory markers, and generally full blood count for other parameters. And I would, of course, assess this child's airway like I would for any other patient. Yes.
Yeah, good. So, okay, right. So that's fine. What would be your options for, if you've talked about anesthesia now, so induction, do you want intravenous versus inhalational?
So I would carefully plan for a induction as well as maintenance and post-op period and destination for this patient. Being a pediatric patient, I would make sure that the induction occurs in the least distressing and safest way possible, so that it involves the parents also up until an appropriate point. If the child, well, I would first and foremost speak to my senior about this case. They would have to be involved because I won't be anesthetizing a child on my own, and really my approach will depend on what they recommend. Having said that, I'm aware that children can be anesthetized with an IV induction with propofol 4 milligrams per kilogram. However, that would involve cannulation, which can be distressing for the child, so it would have to be at least numbed with a eutectic mixture anesthetic at the site. It is possible to also perform a gas induction with sevoflurane. However, that has its own risks and difficulties, and I would have to make sure the parents are appropriately briefed for that as well. For the tonsillectomy side of things, I would make sure that, of course, the airway adjuncts or the ET tube is appropriately chosen, that drug doses are calculated appropriately for the 6-year-old in advance, and that the surgical field is clear without minimizing anesthetic safety, without compromising anesthetic safety.
Because of time, we move on. What would you know about fasting guidelines regarding children?
So just like with any patient, I believe that the guideline for solids is 6 hours post-meal. However, we also need to consider that breast milk has its own time, fasting time. So we like to leave at least 3 hours after that. And then, or I believe it's 4 hours actually, I'm sorry. And then 3 hours for any clear fluids such as water.
Want to talk about advantages of intubating or not intubating in this case?
The advantages and disadvantages of intubating in this case, did you say? Yeah. Well, to be honest, to be perfectly honest, I'm not aware of a tonsillectomy being a case in which you cannot intubate, because if you used an airway adjunct such as an LMA or an an eye gel, the surgeon wouldn't be able to perform the operation. So I think the disadvantage would be that the surgery cannot be performed, which is quite a clear disadvantage. Also, of course, there will be, if it was possible, there would be a significant risk of bleeding in the upper airway, which and potential swelling that could occur in the airway, which would all be indications for definitive airway. So the advantages would be that would be, I believe, the only way of keeping the child safe from aspiration or other airway compromise, such as laryngeal edema.
And it's gone uneventful. However, you were called to the ward 2 hours later because the child is drowsy and cyanosed. What would be your immediate management?
Of course. So this is an anesthetic emergency, and I'd make sure I'd announce that and call for help straight away. I would make sure that I put on 100% oxygen and assess the child in a rapid but thorough manner with an ABC DE assessment. You mentioned the child is drowsy and cyanosed, so I'm suspicious this may be an airway or breathing issue. Clearly the child is not oxygenating or doing gas exchange properly. So my airway assessment would be first to check whether there is any obvious airway obstruction, partial or complete. And I'd make sure I'd open the airway with airway maneuvers or airway adjuncts if appropriate. Depending on what I find, I would then move on to B if there is no concerns in the airway. So I would include...
right, so just because of time to stop you, where would you want to ideally manage this patient?
This patient should be managed, well, at this case, it should be brought back to theatre. So I wouldn't be on the ward for long, hopefully.
And assuming you've done your ABC assessment and then you've stabilized, what will be your plan afterwards?
So my plan would of course be devised with an MDT approach of my anesthetic consultant and the pediatric team, as well as the surgical team. This child is not safe to go home and needs to be kept as an inpatient. I suppose depending on what the cause was or what the problem was, it would have to then be decided what needs to happen next. Okay, good.